Hey guys, my name is Shrey Ghadigaonkar and today we're going to talk about gastric polyps and tumors. Alright, so the important points you need to mention are pseudotumors, the epithelial neoplasms, so these involve adenomas and carcinomas, neuroendocrine neoplasms, mesenchymal tumors, and lymphomas. Right. So the first topic we're going to talk about is pseudotumors. So, uh, so it's important to note what a pseudotumor actually is and why is it called pseudotumor. So, pseudotumor basically stands for uh, they're not actually tumors, which basically means it's false in tumors. So the main difference between tumors and pseudotumors is that tumors are basically monoclonal proliferation of cells. However, pseudotumors are not. Right? So one of the most important component in pseudotumors are polyps. So polyps are basically masses that project above the level of the surrounding mucosa, and they identified in 5% of upper GIT endoscopies. They may develop as a result of epithelial or stromal cell hyperplasia, inflammation, and or ectopia or neoplasia, right? So as we know, there are two types of pseudotumor. They may be either inflammatory or hyperplastic, which is the most common, or they may be fundic gland polyps. So these can either occur sporadically or in individuals with familial adenomatous polyposis. So this is a genetic condition. At the end, it's important to note that macroscopically, the pseudotumors and tumors are somewhat difficult to differentiate just by looking at them, and therefore you may most in certainly almost all the cases you need to do a biopsy. So the first type is inflammatory or hyperplastic polyps. So these are the most common ones, and these are basically reactive lesions associated with chronic gastritis, which initiates the injury that leads to reactive hyperplasia and polyp growth. So macroscopically, these may be larger than 1 centimeter. They may be multiple, and they may be ovoid with smooth surface or erosion. So these kind of characteristics are also found in tumors, and therefore it's harder to distinguish. However, when you do a microscopy, in these cases, there's usually dilated hyperplastic glands, as in the case of hyperplastic polyps. And in the case of inflammatory, there may be presence of inflammation. So you might have inflammatory cells, for instance, and these are referred to as inflammatory polyps. And they may also be ulceration as well in these cases. The second one is fundic gland polyp. So for those who don't know or who don't remember, let me just go through the anatomy of the stomach. So you basically have the stomach over here, right? All right. So this right here is the duodenum, and this is the esophagus. This region over here is known as the cardia. This region over here is the fundus. So the when we talk about fundic gland polyps, we're mainly referring to this region. You have the body over here, and this region is divided into the antrum, and this is the pylorus. So you have the sphincter over here, right? So the polyps associated with FAP, which is the familial adenomatous polyposis, they may show dysplasia. However, these almost never progress to become carcinoma. The second point that is important is that fundic gland polyps prevalence has increased due to the use of proton pump inhibitors. So proton pump inhibitors are basically these specific kind of drugs that are used to decrease the acid production in your stomach. And if you remember from physiology, uh, this you usually have a hormone known as gastrin, which is responsible for increasing the gastric acid secretion. And if you use a specific kind of drugs that decrease the gastric acid secretion, the cells that release gastrin usually usually the cells that release acid usually undergo glandular hyperplasia. And if you remember from physiology, the gastrin levels are actually sensitive to the gastric acid levels, and therefore, if you have low gastric acid, which is related to the pH, more gastrin is produced, and gastrin is responsible for stimulating the parietal cells. Macroscopically, it may be in the body or the fundus, and these are often well circumscribed with smooth surface, and they can also be single or multiple. And macroscopically, you usually see cystically dilated irregular glands that are lined by flattened parietal and chief cells. So over here, I have a picture for you, which is a fundus gland polyp. So as you know, as you can see over here, it's actually several of them. So it's one here, one here, one here, one over here. And endoscopically, they appear as like glassy, smooth, round polyps, and they're often multiple. And over here in the B part, it's actually a low power histological view displaying the dilated glands. So these are basically dilations in the glands. And they may be lined by parietal cells. So the P stands for parietal and the M stands for mucous cells. And in the C image, we have a high power histological view, which shows the flattened parietal cells over here, this region, and the mucous cells in this region. And over here, it's parietal cells as well. Coming to epithelial neoplasms, so one of the more important components of this topic. So you have adenomas. So adenomas, as you guys remember, these are benign. However, they're more rare compared to carcinomas in the stomach. Uh, Adenomas or adenomatous polyps are true benign neoplasms, and these almost always occur on a background of chronic gastritis with atrophy metaplasia. Uh, Regarding the risk in individuals with FAP, it's more common. It's usually increased, and it's more common in men compared to women. Um, since these are neoplasms, there's usually a small risk of these neoplasms, these adenomas, developing into adenocarcinoma, and that specifically comes with increase. There are usually increase in lesions that are greater than 2 centimeters. And these are precancerous, so there's a high risk of malignancy than in the colonic adenomas. Macroscopically, these are solitary and usually less than 2 centimeters. However, if they increase greater than 2 centimeters, you want to consider a malignancy, and these are mostly in the antrum. Macroscopically, there's usually an intestinal type called columnar epithelium, and there's varying degrees of dysplasia. Coming to the carcinomas, so the most common type of cancer in the stomach is the gastric adenocarcinoma, and it's basically a proliferation of surface epithelial cells. It's important to note the relation between H. pylori infection, which is associated with chronic gastritis, and this can lead to gastric adenocarcinoma. But you also have other kinds of associations, which include EBV infections. Uh, so these can be asymptomatic clinically, or they may have symptoms that resemble chronic gastritis and peptic ulcer disease. And you may have other kinds of non-specific symptoms like weight loss, anorexia, epigastric abdominal pain mimicking peptic ulcers, and occult bleeding, iron deficiency, anemia, and that's usually due to the bleeding, the chronic bleeding, early satiety, and these some of these are usually associated with more advanced stages. So that means the cancer has progressed too far. Regarding the epidemiology, so there's actually a decreased incidence in the USA, and there's an increased incidence in the Japan, and the examiners may ask you why there's an increased risk in Japan, and that's mainly due to the consumption of high amounts of smoked foods. So smoked foods, as you know, they contain nitrosamines, and these are carcinogenic. So regarding the pathology, so we can basically divide the uh, gastric adenocarcinomas into two types. So one of them is the intestinal type, and the second one is the diffuse type. So in the intestinal type, these are the most common ones, and they primarily occur in the lesser curvature of the antrum. And these are your risk factors. So they're usually associated with intestinal metaplasia, nitrosamines, as mentioned in smoked food. Also, important to note that intestinal metaplasia is associated with H. pylori. And as mentioned, these can lead to chronic gastritis, and then you can have the metaplasia, and then you can have the cancer. Smoking as well. For some reason, blood group type A has an increased risk of these types of cancer. You have achlorhydria, which basically means decreased gastric acid production, or no gastric acid production, and chronic gastritis as well, I mentioned, is associated with the H. pylori. Regarding the pathogenesis, so It seems kind of complicated, but it's not. So it's mainly a loss of function mutation with APC, as well as gain of function mutation in beta catenin. So beta catenin, therefore, would be your oncogene, and APC would be something like your tumor suppressor gene. Macroscopically, these are gastric tumors with intestinal morphology. So these tend to form bulky tumors, and they may be ulcerated and composed of glandular structures. So in the early type of carcinomas, usually have two different morphological patterns. So either they can be polypoid, which is basically they form like a exophyt, like if this is your surface of the stomach, you have like a growth over here. On the other hand, you can have an ulcerated tumor, which is basically consisting of an ulcer. And the ulcer one usually has the worst prognosis. In the advanced carcinoma, the invasion usually reaches the muscularis externa, which leads to necrosis, perforation, and peritonitis. So, if we were to briefly go through the histology of the GIT, so as you know, you have four layers. So this layer would be your mucosa, then you have your submucosa, then you have your muscularis propria. So in most regions, these usually have layers. So you usually have like a circular and a longitudinal layer. However, in the stomach, you have three layers. And finally, you have the adventitia or the serosa. So the invasion usually spreads deep into the mucosa. It's pretty, actually, if it spreads deep into submucosa, it's pretty malignant. But in advanced carcinomas, as mentioned, it can basically dive deeper into the mucosa, and it can perforate the lining of the stomach, and as a result of this, you'll have peritonitis because of the inflammation. So microscopically, as mentioned, you'll have intestinal gland formation, and that's because of the metaplasia. So over here, you can see the ulcer. So usually in these cases, these you can see the heaped up margins in this region. Also, it's important to note that you can have two types of ulcers. You can have acute ulcers, or you can also have chronic ulcers. So in acute ulcers, one of the main differentiation from chronic ulcers is that in acute ulcers, they're usually punched out. However, in chronic, they're usually associated with the heaped up margins. So as you can see over here, there's actually heaping up of the epithelium. And this is common in gastric adenocarcinoma. The second type is diffuse type, which is much less common, and the entire stomach is involved. So it's important to note that the risk factors is not associated with H. pylori and intestinal metaplasia, nor is it associated with nitrosamines. And the pathogenesis usually involves a loss of function mutation in the CDH1 gene, which codes for E-cadherin. So if you were to remember anything about the pathogenesis, it would be the loss of E-cadherin. So E-cadherin is involved in this cell adhesion and is often believed to affect tumor invasion by inhibiting cell migration away from the epithelial layer. The tumors often evoke a desmoplastic reaction, which is a morphology referred to as linitis plastica. So I will come back to this in the next slide. And macroscopically, you can see signet cells that are diffusely, basically, they diffusely infiltrate the gastric wall. So it's supposed to be macroscopy over here. And this also is associated with loss of peristalsis. So over here, we can see the linitis plastica, which basically stands for leather lining. Uh, and this is basically characterized by thickening of the stomach wall and its rigidity, which is conditioned by fibrosis. So it's intense fibrosis within the linings of the wall. And symptoms of this type of adenocarcinoma come later compared to other morphological types. So if it occurs, it basically means that the tumor has already reached like a more advanced stage. And you can also see the normal lining, which is like a rugal folds, and over here is the infiltration. So this is an advanced stage. On the right side, you can see the microscopy, which consists of signet cells. So we can see one over here. Signet cells basically a type of cells which are supposed to produce mucus, but they don't, and therefore it's associated with cancer. And so signet cells basically are cells that characterized by a peripheral nucleus with a large like cell, and it contains like this region basically consists of mucin. And these cells basically spread diffusely, and that's probably due to the loss of E. calibre. Regarding the metastasis and the paraneoplastic syndromes, so the metastasis is it can occur anywhere, but the most common ones in gastric carcinomas are the Volkov node. So the swelling is that you can actually see a swelling over here, which is visible, which is in the left supraclavicular fossa, and it's usually a finding associated with enlarged lymph nodes, and it's typical for the lymph node metastasis from gastric cancer, and it can also be found in other abdominal malignancies. The second type of metastasis apart from other organs is the systemary Joseph nodule. So these are basically well demarcated protuberant round purplish red nodules, and this is usually in the umbilicus region, and that may also present with a central ulceration. And this finding also is suggestive of a metastatic lesion of the intra-abdominal pregnancy, and is known as systemary Joseph nodule. Regarding the paraneoplastic syndrome, so there's two specifically associated with gastric cancer, and that's your acanthosis nigricans. So acanthosis nigricans is basically hyperpigmentation, hyperkeratosis, and numerous skin tags, as you can see in this image over here. However, these may not always necessarily mean that it's cancer. It can also be associated with diabetes mellitus or even obesity. On the right side, we have lesser Trailat sign, which is so over here you can basically see the back of a patient, and this can also be associated with colon cancer, and you have numerous light brown raised lesions of different shapes and sizes, and these are basically a seborrheic keratosis, which usually occur naturally in the process of aging. However, they can also be like seen in patients who have gastric cancer. Then you have neuroendocrine neoplasms. So these are also referred to as carcinoid tumors, and they arise from neuroendocrine organs and cells, like the G cells, which produce gastrin. So gastric neuroendocrine tumors may be associated with endocrine cell hyperplasia, chronic atrophic gastritis, and Zollinger-Ellison syndrome, which is a tumor associated with gastrin production. These may cause bowel obstruction. However, that's usually common in most cancers associated with the GIT. Symptoms of carcinoid tumors are determined by the hormones produced by them. In cases of GI carcinoid, the vasoactive substances, in most cases, it's usually serotonin. So these are usually metabolized to inactive forms by the liver. However, if the tumor itself metastasizes to the liver, you can have systemic symptoms. So these may involve like flushing or headache or bronchospasms or even diarrhea. And the prognostic factor of the carcinoid tumor depends on the location and tendency to metastasize. So you can have them, for instance, in the foregut, you can have them in the midgut or in the hindgut. You also have mesenchymal tumors. So one of the most common types of mesenchymal tumors are GIST, which stands for gastrointestinal stromal tumor. These are the most common ones as mentioned, and they arise from the interstitial cells of Kyle, which are the pacemaker cells of the gastrointestinal meningeal system. And these may be benign, borderline, or malignant. Regarding the pathogenesis, it's usually associated with a receptor tyrosine kinase KIT or the platelet-derived growth factor receptor. And these kind of tumors usually they respond to tyrosine kinase inhibitors. Regarding the pathology, so these tumors can grow pretty massive in size, so like up to 30 centimeters. They're usually solitary and they're well circumscribed. These may also be ulcerated as well. As mentioned, they can either be benign, borderline, or malignant. And if they're malignant, as we know, they're associated with metastasis. The macroscopy may comprise of either spindle cells. So these are basically like spindle shaped. You have epithelial cells, so epithelial appearing cells, and they can also be a mixture of both of them. One of the main complications of GIST tumors are basically blood loss and anemia. In case the mass is ulcerated, and with most GIT tumors, if they're large enough, they can also cause obstruction. Diagnosis usually involves immunohistochemistry, detecting KIT, and treatment involves complete resection. So GIST is usually the most common mesenchymal tumor. However, you can have other tumors as well. So these may be leiomyomas, leiomyosarcomas, lipomas, schwannomas, glomus tumors. So this is a gross morphology of the GIST tumor. So in this specifically, they are multinodular and they usually are gray-whitish in color. And finally, we have lymphomas. So these are extranodal lymphomas, which basically can arise in any tissue, but they do so most commonly in the GIT, especially the stomach. One of the most common types of lymphomas in the stomach is maltoma, which stands for mucosa-associated lymphoid tumor, and specifically marginal zone B-cell lymphomas. So if you had to take, I would say the H. pylori infection, which is the most common inducer in maltoma. So if you eradicate the H. pylori infection, the maltoma usually goes away. Microscopically, it's usually diagnostic with lymphoepithelial lesions. And the second type of lymphoma is the diffuse large B-cell lymphoma, which can progress from maltoma. And if it does progress, it's usually uh, they're pretty malignant. Finally, we have a slide which depicts various endoscopic findings of gastric maltoma. So in type A, in slide A, you have a gastritis-like pattern. In the B slide, you have a submucosa-like pattern. In the C type, which is this one, you have a early gastric cancer-like pattern, and this involves the staining is actually the type of endoscopy of here is basically known as chroma endoscopy. So you don't need to know all this; it's just like additional points. And the D type is the ulcerative type. So the endoscopic findings of gastric malt lymphoma are usually variable, and this can make the diagnosis very difficult. So these are the references, and thank you for your time.